Human Services, Finance, and Policy. It is February 22nd. And members, we have before us today Senate File 1160. And I am verifying that we have a quorum. Members, we do have a quorum. Senator Rosen, will you please move your bill and begin your presentation? Members, for process purposes, I'm sorry, Senator Rosen, we're going to do amendments today, send it to Commerce for the work that needs to be done there. We do not have a fiscal note before us. When the fiscal note is ready, we will hear the bill again for review of the fiscal note and make any further necessary amendments. So, Senator Rosen, welcome to committee. Please proceed.
Thank you, Madam Chair. I'd like to move Senate File 1160. And Madam Chair, this is the Telehealth Bill, which says basically the general definition is the use of electronic technology to provide healthcare and services to a patient when the provider is in a different location. The original Telemedicine bill was passed in 2015, and I was the chief author. Senator Clausen, Senator Nelson, Senator Eakin, and Senator Lori were on the bill. All 50 states have a definition of telehealth, telemedicine, or both. All 50 states have Medicaid program reimbursement for live video. 21 states have Medicaid reimbursement for remote patient monitoring. 27 states reimburse service to the home. 26 states reimburse services in the school-based setting, and 18 states reimburse Medicaid for store and forward technology. But Senate File 1160 is much cleaner. It's an updated version and clarifying the current statutes with some major changes, which involve basically the use of telephone, which is it has always been in the past language. We're just making sure that it's clarifying and that it's peppered all through the statute. And it's listed as audio only communication. It also designates the site of service, which must not be limited on a basis of geography, location, or distance of travel. And we also eliminate the three visit for services per enrollee per calendar year, which is, so we're basically repealing that. Because of COVID and all of the executive orders and the peacetime emergency, there's been a lot of changes to this technology and to the use of telehealth. And so most of this bill follows what has been implemented because of COVID, except for the piece on medical marijuana, Madam Chair. It's a really great place to start the discussion on this. I will let the testifiers talk of the benefits of it. But Madam Chair, first I think if you would prefer, I'm going to go ahead and move the amendments. Would that be okay?
Please, Senator Rosen. We've got a whole list of amendments here, so I'm going to let you start your markup. And I know your first amendment's generally treated as an author's amendment, but I'll leave it to your discretion on the first one if you'd like to explain what you're doing.
Yes, does it just mean the very first one or the first committee?
Generally, the first amendment you offer in your first committee is considered an author's amendment. I think folks here will give you a little bit of grace, but it might be best if you explain some of the changes you're making because they're really good reasons for amending a bill.
Yeah, that's right. Thank you, Madam Chair. Madam Chair, I'm going to go with the A4 amendment.
Members, the A4 amendment should have been distributed to you. Senator Rosen moves the A4 amendment. Senator Rosen, did you want to give a brief explanation on this one?
Absolutely. The A4 amendment, Madam Chair, broadens the use of telehealth for medication therapy management for MA recipients that are taking prescriptions for one or more chronic conditions. It also removes the ambulatory care setting requirement for a pharmacist. It also removes the current geographic requirement for MTM, or the medication therapy management services, where they can be delivered through telehealth, and removes the limitation on delivering MTM services through telehealth to a patient's residence only if performed during a covered home visit. There has been significant work done by the community involving this, and so this is a good amendment, Madam Chair. Thank you.
Okay. Thank you, members. Any questions? I'm going to give a slow count for raising of hands. Seeing no questions, please remember to turn on your video, unmute yourself. All those in favor of the A4 amendment signify by saying aye.
Aye.
Aye. Any opposed? Seeing none, the A4 is adopted. Senator Rosen, to your next amendment.
Thank you, Madam Chair. I'd like to move the A8 amendment.
Senator Rosen moves the A8 amendment. Senator Rosen, proceed with your description.
Thank you. This deals with the changes made for mental health case management, mental health targeted case management, and targeted case management. And it makes conforming changes for the telehealth, incorporating the option to use audio-only communication when appropriate. It's important for the vulnerable population to have the option of either in person or through telehealth. And we are saying on page 1, line 15, at least one face-to-face in-person contact every 6 months. And again, it is for this vulnerable population that we do feel it's important to have this in-person contact. This case was brought to me by Hennepin County. And again, it is open for discussion, but I do believe it's a very, very important discussion, how we're going to deal with this type of specific population.
Members, again, I will watch for hands. Seeing no questions, please turn on your video, unmute yourself. All those in favor of the A8 amendment signify by saying aye.
Aye.
Aye. Any opposed? The A8 amendment is adopted. Thank you, Senator Rosen. To your next amendment.
Thank you, Madam Chair. As you can tell, there's been quite a few adjustments to this bill, but I have the A6 amendment I'd like to move, Madam Chair.
Senator Rosen moves the A6 amendment. Please proceed, Senator Rosen.
Well, there's basically some minor changes, but it also clarifies that audio-only communication must be scheduled and that the standard of care for this service must be met through audio-only communication. So we really wanted to make sure if it's going to be telephone, it must be scheduled and that there is a standard of care for this service that has to be met. It also clarifies that face-to-face communication may occur either in person or through telehealth with a priority given to audio and visual communication if available. So we're not mandating any audio only or telephone only. There is a priority given to audio and visual, but I think that's good clarifying comfort language.
Members, again, questions on this? And Senator Rosen, as you explained it to me earlier, it's so a doctor or a care provider can't just call a patient and then bill it as an appointment. It has to be part of the course of treatment. It has to be a planned and scheduled medical appointment. Okay.
Thank you, Madam Chair, and thank you for reminding me. That is a concern from the plans that there has been some calling out and saying, how you doing? That is not, that's abuse of the telehealth policy.
So, and members, I think that's just reflective of, as we're learning, there are going to need to be changes. So we're not going to solve all of them this year, but Senator Rosen's certainly willing to listen and address concerns. Unmute yourself and turn on your video. All those in favor of the A5 amendment signify by saying aye.
Aye.
Aye. Any opposed? Thank you. And the A5 amendment is adopted. I'm sorry, we were on the A6.
We're on A6, Madam Chair.
Sorry, that was a motion on the A6 amendment. Staff will correct the record for that. And Senator Rosen, your next amendment.
Thank you, Madam. My last amendment, I'd like to move the A5 amendment.
Now we're on the A5 amendment. Thank you, Senator Rosen. Proceed with your description.
The A5 amendment gives the definition for remote patient monitoring and requires the services be covered under private coverage and MA, just as I mentioned. I believe there was 21 other states that are doing this, if medically appropriate. And I want to make sure that that is heard and understood. And if the patient is cognitively and physically able to operate the monitoring device or equipment, or if the patient has a caretaker who can operate the equipment, if the patient resides in a setting that is suitable for telehealth, that does not have healthcare staff available. For MA coverage, it must be a specified chronic condition, must require at least 5 times per week monitoring to manage the condition, and has had 2 or more emergency room or inpatient hospitalization stays within the last 12 months due to the condition, or the recipient's provider has identified that telemonitoring services would likely prevent admission or readmission to a hospital, emergency room, or a nursing facility. And I know Senator Cran has been very abreast on this issue, and perhaps he could say something on this, Madam Chair.
Thank you, Senator Rosen. I'm looking for hands, and I'm not seeing Senator Cran.
Senator Cran's hand is up.
Is it? For some reason, he is not. All right, Senator Cran, please proceed.
You need a new dashboard for you, Madam Chair. So I do speak in favor of the A5 amendment. I really think that this entire conversation, as I put on my hat as an individual, as well as the serving on aging, I really think that when we look at home patient monitoring and what's going to evolve over the next 3 years, we are going to have many conversations as this evolves. I think the home maintenance monitoring, moving from I've fallen and can't get up to really sophisticated monitoring capabilities, not only for the healthcare systems, but for the families themselves to be able to monitor in real time and keep somebody out of being in a nursing home, yet probably replicating and providing 24-hour management services or monitoring services, I think is going to be our future. And I don't think it's that far away. So that's why I support this amendment, as well as our entire conversation today on how will we foster and make sure that the healthcare companies and the providers and everybody, the needs are met, but we improve care and we lower costs and we make sure that the entire process is reflective of the consumer needs and the protection, as well as providing great care to everywhere. And this one is really close to I think the aging in place and how much better that's going to improve the overall quality of health, and being able to monitor change in patient health in many cases, I think before they're aware, and to be able to bring the healthcare provider in and the family. I think we're on the cusp of that. And so I appreciate this amendment. I support it. Thank you.
Thank you. And Senator Wickland.
Thank you, Madam Chair. I just had a question for Senator Rosen. Just wondering, is this description of what an eligible service or telemonitoring service is for medical assistance, is that something you worked on with DHS and the specific criteria? Just asking because it's so much different from the one for all the rest of the carriers. So,
Senator Rosen.
Thank you, Madam Chair. Senator Wickland, no, I did not. I have talked with DHS on this, and as I said, this is kind of a work in progress as far as what is eligible, what the diagnosis and the services that they can receive for congestive heart failure, cancer. I mean, that's a list that needs to be pulled out more, I think. I worked with the nonpartisan staff, Ms. Kavanaugh, on this, and this is what other states have done. And I've talked to some of the representatives of that provide remote patient monitoring technology. So that's what I've done.
Senator Wickland, anything further?
I guess I would just hope that you would reach out and talk with DHS about it, just to make sure that the definition meets what they're seeing as a good basis for the telemonitoring services. This is it seems quite prescriptive, and maybe that's warranted in this case. I'm not saying it isn't, but I just would hope that you work with them on it. Thank you.
Thank you.
Thank you. And Senator Wicklund, Senator Rosen, this isn't a concern about the amendment, but to the extent we can stay aligned between private coverage and our public plans, I think that's important public policy so that we have less confusion in our system. And then as the feds make changes, that we try to stay in conformity or aware of conformity. And so I support the A5. I think it is important. And Senator Rosen, I am sure that the department will reach out and we'll do due diligence before we come back on this. Any further questions on the A5?
Madam Chair, I don't know if there's a further question, but I do need to tease out more the services that are eligible. I think what's listed here, you could do, the well baby pregnancies. There's a tremendous amount of really, really solid chronic conditions or temporary chronic conditions that would be eligible. So as we have all said, this is the start of the conversation. And I'm sure this is going to change by the time it comes back immensely to you.
Thank you, Senator Rosen. Members, we're going to get ready for a vote. Please unmute, turn on your video. To Senator Rosen's A5 amendment, all those in favor say aye.
Aye.
Any opposed? Okay, thank you, members. The A5 amendment has been adopted. And Senator Rosen, I understand that there is another amendment. Would you like to discuss that now, or would you like to move to testimony?
Madam Chair, do you feel like we have got a thorough description of the bill? I could just briefly run through that. That would be okay.
Senator Rosen, you're right. Let's go through your bill description. And then I think we'll go to Senator Curran's amendment and public testimony. So.
Thank you, Madam Chair. As I said, this is kind of a rewrite of the past, the 2015 legislation, a little more defined, but it rewrites the current telehealth coverage statute by changing terminology from telemedicine to telehealth and clarifying the definitions and coverage requirements. It also defines the terms for distant site, healthcare provider, health carrier, health plan, originating site, and store and forward transfer, which is all current language. I want to make sure that everybody understands that. We've been getting questions about, are we changing this? Are we changing that? No, the 1160 is a new rewrite of the old bill. But the changes of current law are, number one, the healthcare provider means any licensed or registered healthcare provider practicing within their scope of practice. What's important for plans was that it specifies that telehealth includes audio-only communication if the communication is a scheduled appointment and the standard of care for that service can be met using audio only. Also, coverage for services, and this is a change too, coverage for services must not be limited based on geography, location, or distance of travel. It also prohibits a health carrier from creating a separate network or providing incentives to enrollees. This is something the plans oppose this new language. However, we did put in language that says any reasonable medical management techniques for comfort language. And I could direct you to that. That's on page 3, line 11. That's new language. And this is what the health plans did want. There's no language in here to require telehealth. And it also prohibits providers from requiring specific telecommunication technology or equipment as a condition for coverage, but they must follow HIPAA standards. And then for the MA coverage of service delivered by telehealth, it removes the current coverage limitation of 3 telemedicine services per enrollee per calendar year. It also permits the commissioner to establish criteria for the safety and efficacy of delivering a particular service through telehealth. So we're just clarifying the parity issue from 2015. The plans would like to adjust that, but that has been in place. And I think there is a request for adjustment because there is an increased usage of telehealth, obviously, through COVID. but you've always been able to use telecommunications, and there's always been a strong parity portion of that telemedicine bill. But I think this would probably be a good time for the testifiers to talk about the benefits of telehealth or the problems with it. Thank you, Madam Chair.
Thank you. And I know that Senator Coran does have an amendment, so we'll let the testifiers go through and then Senator Coran will offer his amendment. So my first three testifiers, Dr. Kurt Devine, Dan Andreessen, and Bobby Patrick. And members, we're going to try to keep testimony to 3 minutes. We will make a couple of exceptions based on prepared remarks. So Mr. Devine, please proceed.
Thank you, Madam Chair and members. My name is Kurt Devine. I'm a family and addiction physician in central Minnesota, and I'm actually here representing the MMA today in strong support of 1160. I think one of the things we all can agree on is that access to healthcare, always has to be a priority. And I think COVID kind of made this pretty challenging for all of us and kind of opened our eyes, I think, to the usefulness of telemed and telehealth. And I think that, really we want to always make sure that we're giving that appropriate care to the Minnesota residents. And I think this is one method to do that. Obviously, the governor's executive order that allowed the expansion of this has really been critical during this time to give really these patients the timely and appropriate care that they really deserve. And I think, we all understand that telehealth is not really always the substitute for in-person, but can be. And in some circumstances, it can be the best that we can get. It's another delivery model, and I think can be done well. There are things that I have found that telehealth visits, haven't been adequate for. And clearly, as physicians, when that's the case, we bring those patients to our clinic and do a more hands-on eval. So I think that if we're all reasonable and we bring the patients in that need to be brought in, I don't think that there's ever really a concern. In my particular circumstance, telehealth visits have been particularly helpful in that I'm rural and I also do addiction medicine. And often these are patients that really lack transportation and have other access issues. So often the addiction patients that I see as an aborted addiction doctor are more complicated and come from a long ways away in rural Minnesota. So it's been very important. I think one of the things to remember is that when in addiction, one of the big things that we look at is getting patients back to the workforce. And often telehealth has been a way for us to allow them to work, but yet to do their visits when they're on break, when they have time to do it on their own schedule and not ours. And often I can tell you, I've done telehealth visits at the base of a tower that a patient was about to climb, or in their, as a car salesman in their car lot, sitting in a car. I've done many of them in mechanic shops or in break rooms of clinics with patients that are in communities near us. So the other thing I think that's important is that telehealth does things that in-person doesn't do. And I've had the most wonderful visits with patients. And I often think of one that I did on the reservation near us where I got to see the patient's home. I got to meet her grandchildren. I got to see the puzzle she was working on. And so there's so many other ways to view the patient when we do telehealth. I've had times too where out here where our internet is not the best. And I can tell you my internet at my home just got good enough to do a video at my house. So even in my neighborhood, video is sometimes not available. And so sometimes we do have to move and go to, telephone visits. And I think often these can be just as good, especially when we look at the elderly who don't have smartphones. They often don't have internet and don't care about internet, to be honest. But these phone visits may be the perfect solution to their inability to get to your clinic. One of the issues always is quality.
Doctor, I do want to thank you. I appreciate very much your perspective. We're going to try to keep moving. Thank you for your time today. Mr. Andreessen, followed by Bobby Patrick and Bentley Graves.
Thank you, Madam Chair, members of the committee. My name is Dan Andreessen with the Minnesota Council of Health Plans, the trade association representing Minnesota's nonprofit insurers. Thank you for the opportunity to testify today, and would also like to thank Senator Rosen for reaching out for dialogue on this bill, and we're committed to continuing this dialogue as the bill goes forward. The legislation, as Senator Rosen mentioned, the legislature initially addressed the issue of telehealth in 2015, and a lot has changed in healthcare delivery since in these past 6 years. Technology has evolved towards easy to use free applications. Technological literacy has advanced, and patients who face distance, mobility, and time constraint challenges have become accustomed to using these new platforms to seek the care in the space and time that works for them. We all know the use of telehealth has exponentially increased due to the COVID-19 pandemic, so much that our health plans have seen a more than 3,000% increase in telehealth claims compared to 2019. The council and our nonprofit members fully supported this expansion, and I want to be clear, the council fully supports the ongoing use and expansion of telehealth for all Minnesotans. As Senator Rosen mentioned, we do have some concerns with the payment parity language in Section 1, Subdivision 5, and also the language regarding restrictions on virtual networks and incentives. The 2015 law established that providers would receive the same level of reimbursement for telehealth as they would for in-person services. And this language was included in a large part to help providers scale up telehealth technology. Session law passed last session temporarily extended those requirements for telephone services. And the council supported these changes to ensure patients could maintain access to providers. And we also supported these changes to ensure that providers could still see patients and stay financially afloat. The council is not advocating for any changes so long as a peacetime emergency is in effect. Those who follow the work of this committee and other health committees of the legislature will notice a common refrain that no matter what the issue, that we're concerned about healthcare being expensive, the cost of care continuing to rise, and that everyone agrees that we need to do something to lower these costs. The US spends more in healthcare per capita than any country in the world. And according to CMS, the US healthcare spending rose 4.6% in 2019, reaching $3.8 trillion. These costs are borne by patients and out-of-pocket costs for services, health insurance premiums, and taxes to pay for state public programs. It's not easy to find policies that can bend the cost curve, but telehealth has that potential. But only if we're thoughtful in our approach to discuss what is the true cost of care using telehealth and to seek payment parity with value-based models. In fact, if parity remains, telehealth may increase overall healthcare spending. A significant portion of telehealth visits should be substitutional, but in certain circumstances, it may become additive if people seek care for ailments that they otherwise would not have sought for care in the past. And there's also the potential for misuse, and we appreciate Senator Rosen adding in the language regarding cold calls, which we have seen over the past year, or folks calling into clinics for information. Now, studies from the Commonwealth Fund and the National Government Association are signaling that costs will increase if states pursue a single parity payment model, rather than one focused on quality and value. Now, we agree providers should be paid for their expertise. They have skills that they've learned and developed from years of practice and study, and they should be compensated for the service they provide. However, it's also likely that the overall costs providing care for a phone call or video chat is less than when a person's in a clinic. And we believe these savings from telehealth should be passed on down to the consumer. This can only happen if we remove payment parity and instead go to a method where payers and providers negotiate the appropriate terms for reimbursement and reflect the services rendered in a manner that is best for the patients being served. It's important to note that moving away from parity does not necessarily mean paying providers less for telehealth services. It could be less, it could be a parity, or it could be something that's increased when tied to quality. As health plans, we're entrusted with offering our enrollees the best quality care at the best value for their premium dollar. And this can be achieved through value-based incentive models where providers who provide higher quality care to their patients have better outcomes and have a higher reimbursement. This then incentivizes those with a lower reimbursement to improve patient outcomes. We know the debate will continue on this bill, and we're committed to meet with Senator Rosen and other stakeholders to craft a bill that finds long-term solutions that are best for patients and can address increasing healthcare costs. Thank you.
Thank you very much. Continuing, Bobby Patrick, Bentley Graves, and Dan Dwight. Go ahead, Mr. Patrick.
Thank you, Madam Chair. Senator Rosen, members of the committee. My name is Bobby Patrick, and I am the Vice President of Strategic Growth and Policy for the Medical Alley Association. I appreciate the opportunity to share comments today on the Minnesota Telehealth Act. With a strong digital health industry, collaborative care delivery models, as well as providers and plans committed to improving the value of care, Medical Alley was already leading the enhanced integration and adoption of telehealth prior to the pandemic. These efforts were greatly aided by you in adopting temporary adjustments to existing telehealth statutes to facilitate the ability to access care in a convenient manner. Moving forward, our members made it clear that our goal should be to ensure continued patient access to quality remote and virtual care while providing the flexibility necessary within state law to adapt to innovations in technology and care delivery. Before moving into comments on the bill itself, I'd like to thank Senator Rosen for her continued leadership on this issue and significant engagement with stakeholders on this legislation. As this is only the first hearing on this bill, I will keep my comments brief. First, we greatly appreciate expanding the definition of originating site to the location of the patient when they are provided telehealth. We are also thankful for the author's inclusion of telemonitoring via an amendment. This will help to provide and protect the flexibility to use the most effective care delivery methods available to manage and treat chronic or acute conditions, help keep patients at home, and avoid costly emergency room visits or hospital readmissions. Including clarity on the coverage of telemonitoring is a significant priority for us, and we are grateful for its inclusion here. We look forward to continuing to work with the author and others on the committee on these provisions as the bill continues to move through the process. We also appreciate the modification of definition of telehealth in this legislation. As we have shared with the author, however, we believe that the definition outlined in Senate File 780 may be a better approach. We look forward to continuing discussions with Senator Rosen on the definition of telehealth as this bill moves forward. Similarly, we believe that the phrase store and forward can be removed as the concept and associated technologies are better termed asynchronous. This will provide clarity and allows for flexibility as technology and care delivery develops in the coming years. We also support the addition of language making clear that value-based arrangements or payment models are not bound by the payment parity portion of this legislation. As the healthcare community as a whole continues to look to move away from the fee-for-service model, it is critical to provide clarity to plans, providers, and innovators that these type of forward-looking care models can operate in the way that makes the most sense for patients within this framework. We have concerns with language limiting patient ability to access networks that do not include network providers who provide in-person care for the same service. This language potentially could inhibit the development of innovative care models or other care plans that are able to deliver high quality care for a lower cost in certain situations. We are also working with our members to better understand how the restrictions on technology and equipment will impact them and look forward to talking with the author to learn more about these subdivisions. We do appreciate the updated language related to audio-only telehealth visits, and we'll be engaging further with our membership on these provisions to better understand their impact. Ultimately, this bill takes significant steps toward ensuring patient access to quality care and providing the statutory flexibility necessary for future innovations in technology and care delivery. We are grateful for Senator Rosen's leadership on this bill and look forward to working with her, you, Madam Chair, and the rest of the committee on this legislation as it moves forward. Thank you.
I'm sorry. Thank you, Mr. Patrick. We're to Bentley Graves, Dan Dwight, and then Tricia Stark. Welcome to the committee, Mr. Graves.
Thank you, Madam Chair and members, and thank you, Senator Rosen. I want to echo the comments of Mr. Andreessen and Mr. Dwight, or Mr. Patrick, and thank you for your proactive outreach thus far in development of the bill and discussions around the bill. That's been greatly appreciated, and I think we've seen a good bit of positive and productive change in the language even here today with some of those conversations. So thank you. We at the Minnesota Chamber, we represent 6,000 employers across the state, over 500,000 employees, and we regularly survey our members about a whole host of issues affecting them, including healthcare issues. And this summer, as part of our survey, we asked them, given the challenges they have faced, they and their employees have faced with regard to the pandemic, were there any changes that were top of mind for them that they plan to make with regard to their health benefit offerings? And fully a third came back and said that yes, indeed, both for access reasons and cost reasons, that they were looking at extending telehealth in a more proactive way to their employees, again, to help increase access and hopefully over the long term be another tool in the toolbox to help manage cost growth. So as a result, this is an issue that our membership has a significant interest in. And so again, we've appreciated the opportunity to dialogue with Senator Rosen and other stakeholders thus far. And that certainly extends to some of the changes that were made in the A5 and the A6 as it related to schedule visits for phone calls and also remote patient monitoring. Those are both already discussed, so I won't retread that that ground. Going forward, we certainly want to continue to be engaged in the discussion about the bill. There are a number of things that we think certainly deserve additional discussion. Most of which have been mentioned here already, but all of which have to do with the fact that the landscape around telehealth and healthcare more generally is changing rapidly, both as it relates to kind of coming, what we've learned during and coming out of the pandemic, but also other forces that are at play and have been at play for some time. We too would like to have more conversation around the language regarding virtual networks. We've noticed in other parts of the country new plan design popping up, really leveraging access to kind of virtual first primary care and other services that in those parts of the country have been offered to the public and to the market at a pretty significant cost savings to the covered life, to the enrollee. And so, we want to make sure that as we're kind of wrestling with this here in Minnesota, that we don't kind of unnecessarily foreclose those options for new products that could bring benefit to employers and their employees, both as it relates again to access and cost. Similarly, as was mentioned by both Mr. Andreessen and Mr. Patrick, we have long advocated for a faster, greater movement towards value-based purchasing and away from fee-for-service. And we certainly would like to make sure that as this important bill moves forward, that there are those important allowances to ensure that we have a construct here as it relates to telehealth that will support that movement and facilitate it going forward. I also just want to mention that we have had some conversation about parity. Over the last number of years, we were involved in that discussion in 2015 as well, and we're certainly not looking to relitigate that discussion. But as some of these issues kind of impinge on that parity discussion, and there's an opportunity to kind of think more creatively and proactively and look out ahead to the way that the market is developing as it relates to value-based purchasing, virtual networks, and other things that we certainly want to continue to have that conversation as well. So thank you, Madam Chair. Thank you, Senator Rosen, for the engagement thus far in the work on this important issue.
Thank you, Mr. Graves. Next, we'll have Dan Dwight, then Dr. Stark, and Dr. Weingarten. Mr. Dwight, please proceed.
Good afternoon, Madam Chair, members of the committee. Thank you for listening to me today. My name is Dan Dwight from the Minnesota Business Partnership. Senator Rosen, thank you very much for working on this really important issue. We support telehealth and seek a solution that works for providers and payers. It is able to evolve as technology evolves. As proven by this recent pandemic that we're all living through, telehealth is very important for patient access. We need to be very cognizant of being able to protect against frivolous overutilization in order to keep costs down. Patient outcomes are very, very important, and I think that's something that we really need to focus on as we go through this. We do support value-based outcomes and look forward to having that be a part of this discussion. A lot of this has been said, and I want to echo what Mr. Graves and Mr. Patrick have talked about, so I'll keep it relatively short. Remote patient monitoring, really appreciate some of the changes that were up in the amendment and that we've discussed offline. It's important to note that it is different than routine care and that we should continue those discussions. Like I've said, we look forward to continuing these discussions about the inclusion of telephones and other issues surrounding parity and some of the other tangential issues, and really look forward to working with you as this bill moves forward. So thank you, members. Thank you, Madam Chair.
Thank you. Dr. Stark, then Dr. Weingarten, and Mr. Edwards. So Dr. Stark, welcome to the committee. Please proceed.
Thank you. I'm Dr. Tricia Stark. I'm a licensed psychologist and chair of the Legislative Committee for the Minnesota Psychological Association. Thanks for the opportunity to speak to Senate File 1160, the Telehealth Bill. COVID has had an enormous impact on our society. One of its positive outcomes is the expansion of the use of telehealth, such that many more individuals are able to access mental health services. This bill seeks to make permanent the adjustments to telehealth, which have been so successful at engaging people just when the needs for mental health services have skyrocketed, with the CDC estimating a 40% increase in individuals reporting struggles with mental illness and substance use disorders. Several aspects of this bill are extremely important to addressing unmet mental health needs. The change in both originating and distant site allows patients and providers to be where they can best be for optimal service provision. Unlimited sessions of telehealth allows for the provision of services such as day treatment and independent living skills assistance needed by individuals with serious mental illness who are unable to access these services in person. Continuation of audio-only services using telephone is extremely important. Using phone-only services has opened up care to previously underserved populations, such as rural individuals unable to access broadband, the elderly, and typically disenfranchised groups where health equity is an issue. A telling example of the need for audio services came from one of our psychologists who does a support group for women in domestic violence situations. Because they can now join by phone, she's had numerous women in difficult situations from across the state join the support group so that they are now getting help. And maintaining the same provider networks as is provided for in-person care is crucial to care coordination and adequate oversight to protect the public. Telehealth is not for everyone, and it's important that this bill does not require its use. This will allow patient and provider to make an informed choice about what type of service is best suited to their situation. Please support Senate File 1160 as it allows for expanded quality care for individuals unable to access services in person. Thank you.
Thank you, Dr. Stark. Next, Dr. Weingarten, Mr. Edwards, and Mr. Hoffman. Dr. Weingarten, welcome to the committee. Please proceed.
Thank you, Madam Chair, Senator Rosen, and all the other senators. My name is Dr. Thomas Weingarten. I'm a board certified addiction and adult psychiatrist, 25 years of practice. I'm also a member of the Minnesota Psychiatric Society Legislative Committee, as well as medical director of North Star Regional Treatment Centers, which is the first 1115 waivered treatment center in Minnesota, which brings federal dollars into Minnesota. The Minnesota Psychiatric Society represents Minnesota's nearly 500 psychiatric physicians, strongly supports Senate File 1160, which would make increased telehealth access a permanent part of Minnesota's healthcare system. Both providers and patients want access to telehealth to continue, must act to ensure this happens permanent before it expires on June 30th, 2021. 25 states have expanded care, and many have also expanded equal reimbursement. When the pandemic began, the shelter order was implemented. This immediately created a lack of access to care. Isolation, fear rampaged our state, and telemedicine was a vehicle that made it possible to respond to this epic firestorm. Our state's legislature and DHS acted decisively in approving telemedicine, and we're able to stave off an even bigger disaster. COVID-19 will not be stopped by vaccines, only decrease mortality. The disease will continue to spread even with vaccines, so the need for ongoing mitigation necessitates ability to see patients by telehealth. Why drag patients into office, expose them to and staff to a disease? We could do it by a better option. Masks are an essential tool to preventing the spread of the disease, but they are a serious barrier to mental health care. With telemedicine, I can see patients' face and see the suffering and despair. And just as importantly, my patients can see to my face. I can convey my empathy and concern and helping them to believe that there is hope. In MICD, we do not need to touch, draw bloods, etc. to do quality care. It's not decreased by telemedicine. It is improved. A serious barrier to care is lack of access to care. Most mental health clinics are backed up months. Telemedicine has dramatically sped up the access to care, decreased the waiting list, and significantly has also dramatically lowered the need for more expensive hospital emergency visits. Just this past week, I had 4 patients that called in suicidal to my office in a crisis. We were able to add them during our schedule on telemedicine. And the results, they were given care and prevented hospitalization. One of those patients had an internet problem and the visit was interrupted. It was not able to restore transmission. Fortunately, I was able to call the patient, complete the interview, and was thus avoided disaster. The patient still got the same level of care as any visit. They got the same medical expertise. Access to care is not just exclusively for rural. Our patients are oftentimes homeless or they're elderly and they don't have access to smartphones or technology. Should they be denied care if we can use a phone in its place? Lastly, if insurers are allowed to create separate provider networks for in-person versus telehealth services, that would make telehealth treatment less accessible for patients. The telemedicine visit incorporates the same amount of work by the clinician as in person. We review our charts. We go through all the past history. We can look at what they've had before. Again, it takes the same amount of work. On top of that, we still have to pay our staff. And again, the costs have not gone down for the telehealth care. And if we decrease what we get paid, it will definitely put us out of business. So the mental health substance abuse disorder treatment services need to be sustainable, which requires equal reimbursement rates for telehealth and in-person treatment. Thank you, Minnesota DHS and elected officials, for seeing the need to implement telemedicine, act decisively to implement this care has helped stave off a bigger disaster. Now we are asking you to extend the vehicle since it is a way to forge forward, improve our overall care for everyone. Thank you for your time, and I'm available for questions.
Thank you, Doctor. And Rob Edwards, followed by Evan Hoffman and Dr. Sarah Manny. Mr. Edwards, please proceed.
Madam Chair, members of the Health and Human Services Finance and Policy Committee, thank you for this opportunity to speak on behalf of the Minnesota Telehealth Act. My name is Rob Edwards. I'm the CEO at Lee Carlson Center for Mental Health and Wellbeing. I'm also on the board of directors at Aspire Minnesota. So I speak to you today from the perspective of a mental health agency leader of an agency that serves 6,000 individuals of all ages each year with a variety of mental health interventions. And our association provides children's services providers, serve youth, family, children and youth from across the state. A silver lining in this pandemic has been our discovery of how effective telehealth via two-way screen and telephone support has been in supporting and maintaining the well-being of our clients from the very beginning of social distancing and stay-at-home policies. We greatly appreciated the A8 amendment and greater inclusions of the full mental health continuum, though we are concerned that the language has excluded children's services and mental health target case management. And we hope to work more with you on that legislation as it advances. One case in point is our intensive mental health services for children in foster care, a program called ITFC. When lockdowns began, we received more referrals than typical. Our use of phone and telehealth connections with children and families helped us weave a very intentioned and responsive web of support for children living in foster care and their foster families and biological families. These clients were some of the most vulnerable in our care during the pandemic, but outreach via phone and video introduced new ways to leverage technology to respond rapidly, consistently, and responsively to the mental health needs of kids and families. When families don't need to plan travel or plan around other commitments, they can schedule a session during a narrow window of time. Instead of going without that care, we gain a clinical edge in moving that dial forward with kids on their path to healing from trauma, which would simply not have been the case without the convenience of technology. Telehealth has already started playing an innovative role in supporting the accomplishment of treatment goals for many clients. I've seen telehealth enhance client engagement, improve appointment attendance and opportunities for participation, and increase in parent involvement in children's mental health care. Last summer, we surveyed our clients of 200 who responded. Nearly all responded saying that they wanted the convenience and the flexibility of telehealth to remain after the pandemic. This is not because they don't want to be in person face-to-face, but it's because they experienced the advantages of telehealth firsthand, and they believe that telehealth helped their recovery process in one way or another. For most, telehealth offers an advantage in their recovery from debilitating effects of mental illness on their everyday life. For parents, we saw an increase in parent engagement in the child's mental health condition with the use of telehealth. Almost immediately, parents saw a reduction in the unnecessary and time-consuming travel from appointments, the need to miss work, evening activities. With telehealth, they can make appointments, work through their day, most often participating actively and more in the important care that their children are receiving. Adults receiving services for themselves, like the flexibility of telehealth too. They noted that it's hard to commit all the time to take actively the work that they need to do around their mental health treatment goals. But with telehealth, that inconvenience becomes less of a detractor, and they can start work on the depressive symptoms, the anger management, parenting, anxiety. All that seems more possible and more accessible than ever with the option for telehealth. Almost every client we see. Thank you.
Mr. Edwards, I appreciate your testimony very much. Thank you for all you do to help us with this language. Next is Mr. Evan Hoffman, Dr. Sarah Manny, Jason Flores. So Mr. Hoffman, please introduce yourself and proceed.
Madam Chair and members of the committee, my name is Evan Hoffman, Director of State and Local Government Relations for Philips. Philips is a healthcare tech company that aims to bring better care across the healthcare continuum. Many of you may be familiar with Philips through our Sonicare electric toothbrushes, our ultrasounds, our ventilators, Avent baby products, AEDs, or Lifeline, which is the I've fallen and can't get up pendants that were mentioned earlier by Senator Cran. In Minnesota, Philips employs over 400 with 2 main facilities in Plymouth and in Maple Grove. Philips has also been an industry leader in transforming telehealth over the last 15 years, including providing telemonitoring solutions across a patient care's journey, from the ICU to the ER to the home. So we applaud any legislative effort to expand telemonitoring, and we hope to be a resource to this committee and others on telemonitoring. And so therefore, I want to limit my focus to the A5 amendments that were discussed earlier. The A5 amendments are truly a great start. But as was discussed earlier, they do limit the use of telemonitoring to certain patients. So today I want to spend a minute elaborating on why telemonitoring is important, how the existing amendment language is limiting, and then provide a way forward to address these concerns. So beyond the clinical value of telemonitoring that was discussed earlier, as my written testimony highlights, several medical studies have also confirmed that telemonitoring reduces costs by reducing emergency room visits, reducing hospital readmissions, and lowering length of stay. In addition, the American Medical Association highlights telemonitoring as a key telehealth tool to ensuring the uninterrupted care for 100 million Americans with chronic conditions. Moreover, beyond the 21 states mentioned that cover telemonitoring for Medicaid, I'll add that at least 15 states require health carriers more broadly to cover telemonitoring as well. So the A5 amendment language does need a little bit of work because the use of telemonitoring is limited to certain patients that have one of 6 listed conditions, and if they require monitoring at least 5 times per week. However, other patients could also benefit from telemonitoring. For example, take a high-risk pregnant mother who may require a fetal monitor on her abdomen to monitor both her health and her fetus's health. And I'll note that fetal monitors also help with maternal health challenges, which I know is another important health policy goal shared by many on this committee. But we also see telemonitoring being used for patients with other conditions like chronic kidney disease, sleep apnea, stroke, musculoskeletal issues, behavioral health even, and also other types of cardiac complications not listed. And in addition, CMS also covers telemonitoring for patients with acute conditions, so not just chronic, but also acute. This could include a patient who is prescribed a narcotic for pain, whose breathing is then monitored from home. Or take a patient post-surgery who could leave the hospital sooner because they can be monitored from home for risk of reinfection, for example. Other patients don't require telemonitoring at least 5 times a week, but would still value from the service. So take a diabetic patient who would need to have their weight monitored, but does not need to step on a scale 5 times a week. Or take a patient with hypertension who needs only weekly monitoring for long-term management of their condition. So Philips hopes to be a resource to this conversation going forward on telemonitoring. Rather than limit the use of telemonitoring to only certain patients, telemonitoring should be used by the provider so long as the appropriate standard of care is met and there is medical necessity for this service. Thanks again for the opportunity to comment.
Thank you very much. Dr. Sarah Manny, then Mr. Flores, Brian Zerbs. I apologize. Please proceed, Dr. Manny.
Thank you, Chair Benson and committee members, for this opportunity to weigh in on this important issue for healthcare in Minnesota. My name is Dr. Sarah Manny, and I serve as Essentia Health's Chief Medical Information Officer, and I also maintain a pediatric practice in Duluth. On behalf of the Minnesota Hospital Association and Essentia Health, I respectfully request your support of Senate File 1160. While the pandemic has forced healthcare providers to navigate numerous challenges, it has also presented ample opportunities to find new, innovative ways to ensure timely access to high-quality, comprehensive healthcare services. With many patients understandably fearful of COVID-19 and hesitant to come into primary care clinics and hospitals, we have learned that they want to access telehealth services directly from a residential setting. Allowing a home setting to serve as an originating site has become a crucial option for patients to receive high-quality services that prevent the worsening of chronic health issues and potentially reduce potentially avoidable ER visits, all without risking infection or utilizing bed capacity and other medical resources. We've also learned that another important tool to ensuring timely access to healthcare services has been the ability for our providers to utilize audio-only telephone communications to serve patients who only have landline phones or don't have access to broadband internet. This is especially true for our elderly, low-income, and underserved patients who often lack technology and resources needed to access virtual visits. Along with the Minnesota Hospital Association and the other providers and stakeholders you will hear from today, Essentia Health urges this body to continue to allow providers to deliver services directly to a patient's residence, whether these services are provided over a telephone, tablet, laptop, or a personal computer. Essentia Health is an integrated health system serving patients in Minnesota, Wisconsin, and North Dakota. Headquartered in Duluth, Minnesota, we have 13,500 employees who serve patients and communities through our 14 hospitals, 70 clinics, and 6 long-term care facilities. Since March 2020, Essentia Health has conducted approximately 389,000 virtual visits directly to patients, with almost 40% of these visits being offered over the telephone. During this time, these virtual visits have allowed Essentia Health to conduct over 80% of its mental health encounters and avoid countless ER visits and save patient lives. While the number of virtual visits has leveled off since the early months of the pandemic, virtual visits still account for roughly 20% of Essentia's encounters and will remain an important tool to ensuring access to care throughout the rural and underserved communities that we are privileged to serve. As a pediatrician, I have experienced the overwhelming benefits of virtual visits firsthand. And for example, my very first virtual visit that I did after helping to set up this technology was to a child who was an infant who was very ill and at home with the mother. And as I was conducting the visit and taking a history from the mom, it was very clear that this child was deteriorating and deteriorating quickly. I truly believe that this technology saved her life because I was able to make sure that she got to a higher level of care directly from her home instead of having to be transported to my office and then transported back to an emergency room. I also have been able to provide mental health services to teenagers across rural Minnesota, and one in particular stands out. It was a really wonderful experience because I was able to see both parents at the same time, and I hadn't for several years because it took a whole day off of work for them to come into the visit together. It was also wonderful because the church provided the broadband internet that we needed to have to conduct the visit and also a private room for the whole family to be in. And it was a wonderful experience. And I believe it really helped the child's care. So these are just a few examples. There are many more, but I can leverage the benefits of virtual visits for my patients. For these reasons, we ask that this committee to support Senate File 1160. Thank you for your time and consideration.
Thank you. Next, Jason Flores, Mr. Zerbs, and then Angela Youngerberg.
Thank you, Madam Chair and members of the committee. My name is Jason Flores. I'm the State Director of Americans for Prosperity here in Minnesota. Thank you for the opportunity to testify today in support of Senator Rosen's Telehealth Bill. You've heard a lot already today about the benefits, the efficiency, the effectiveness, ease of access, the cost savings. I'm not going to restate those facts, but I do want to put these reforms into a broader context. COVID-19 exposed a tragic reality. In many ways, our healthcare system is undermined by bureaucracy and red tape that prevents doctors, nurses, and medical researchers from actually helping people. Even as access to quality healthcare has become more important than ever, many Minnesotans have been limited in their ability to actually get the care they needed, and not just by COVID. In April of last year, we commended actions at both the federal and state levels, including the governor's executive orders on the subject, that removed many of the bureaucratic barriers that stood in the way of accessing new innovations in care. Across the nation, telemedicine restrictions were waived to allow safer doctor visits from home. Licensing laws were suspended, giving medical professionals the ability to work where they were needed the most, and restrictions on hospital beds and equipment were lifted. The result can't be understated. Lives were saved as a result of these important reforms. These changes were viewed by some as merely temporary, necessary only within the parameters of the much broader healthcare response to the pandemic, but to the pandemic only. But if temporarily removing these regulatory barriers to care helped improve the health of patients, helped deal with hospital capacity issues, and lowered costs, then why wouldn't we want those barriers to stay down permanently? Specific to this bill, it is our hope that Minnesota learn from these pandemic-related experiences and permanently remove unnecessary regulations on the delivery of telemedicine. Thank you again for the opportunity to be here. I'd be happy to answer any questions.
Thank you, Mr. Flores. Brian Zerb, followed by Angela Youngerberg. Those are the only two testifiers I have remaining.
Thanks, Madam Chair. My name is Brian Zerbis. I'm a licensed alcohol and drug counselor with North Star Behavioral Health, a substance disorder program in Minnesota. I'm also here representing MARCH, the Minnesota Association of Resources for Recovery and Chemical Health, a professional organization of 75 agencies representing a workforce of more than 4,000 individuals in the state. The goal of MARCH is to improve access to quality behavioral health services for all Minnesotans who need support and share the value of long-term recovery for the individual, their family, and the community. We appreciate the time spent with Senator Rosen, and we believe Senate File 1160 advances the needs of the substance disorder field. As already discussed, the usage of telehealth was amplified and utilized to great effect during the pandemic. Substance disorder programs continue to utilize this new tool to effectively treat people with substance disorder and co-occurring mental health disorders. I wanted to share a brief example regarding access and how this bill and the waivers have truly saved lives. Last week, we had an individual reach out to us who was living in his car. He was worried about surviving another cold night. He was able to complete an assessment over the phone. He was approved for treatment and admitted to a residential program on Friday. As you can imagine, this individual did not have laptop or access to internet, but he was able to have an assessment and get needed services. This bill supports a workforce by extending the reach of professionals to connect them with people needing treatment. And lastly, this bill keeps clients connected longer, extends treatment engagement, and will support client outcomes. The modifications in Senate File 1160 will allow more opportunities for providers to meet people's needs of Minnesotans in a timely manner. March appreciates the work of Senator Rosen and others on this bill, and we look forward to continuing to work with her on this important legislation. Thank you.
Thank you. Ms. Youngerberg.
Good afternoon, Madam Chair and Senators. Thank you for allowing me to testify today, and thank you to Senator Rosen for your leadership on this bill. My name is Angela Youngerberg. I'm the Director of Business Operations for Blue Earth County Human Services. I'm testifying today on behalf of the Minnesota Association of County Social Services Administrators, known as MACSA, and that represents all 87 counties. Telemedicine, telehealth, such an important topic. All the testifiers spoke to that today. The counties and our provider networks have been using telehealth since at least 2002 in multiple ways. Many advancements and iterations expanding the use of technology have occurred over the years. In 2016 and 2017, Senator Rosen authored a bill to expand the use of telehealth to some forms of case management. Although it was narrow in frame, it, I believe, served a strong foundation for what we went into with the coronavirus pandemic, because we had tested the technology and we knew how to deliver the service in that way. Through the coronavirus pandemic, telehealth became a lifeline for so many individuals who receive case management services, and it has proven that case management can be effectively delivered through this technology. And in fact, Through telehealth, more case management visits were delivered than traditionally. So in times where we were only able to meet with a person once monthly, we were able to meet with them 4 times a month because we were able to meet with them with greater frequency. And so that had such a substantial benefit for many of the people that we serve. Counties support the nature of this bill and the amendments and what it hopes to achieve. Although there is substantial content to the language presented, the testimony today that I'm providing focuses on case management. Counties are responsible for case management services, either providing it themselves or through contracted providers. And so therefore counties have a vested interest in the details surrounding case management, especially in this bill. Counties believe in the value of telehealth, but we want to be sure that the quality and quantity components are both addressed in the language. And so we look forward to working with the author to assure that all forms of case management are addressed through legislative actions with this bill and others. The A8 amendment took a big step in that direction, and we really do appreciate that. This bill specifies certain types of case management that have had some linkage to telehealth in the past, and we hope to assure that a comprehensive approach to telehealth in all forms of case management, including for children and families, is within sight. Ultimately, we want uniformity and how this defines the delivery of case management and assure that it meets the quality standards. Thank you for allowing me to testify today.
Thank you very much. Senator Abler, a question for this testifier?
No, Madam Chair, when we're all done with that. Thank you.
Okay, thank you. She was our last testifier. Senator Rosen, a number of things were raised. Do you have any comments to the testifiers today? Otherwise, we'll move on to committee members.
Thank you, Madam Chair. No, I do definitely have some closing remarks. I think it was obvious the benefits of telehealth going forward. There was one comment by, I believe, Dr. Edwards on the children targeted case management. We're looking into that. We think the A8 amendment takes care of that under the 245.4871, but we're not sure. So we'll definitely work on that and make sure that that is covered.
Thank you. And then Senator Curran, I know you had an amendment, so we'll deal with your language and then we'll go to Senator Abler.
Thank you, Madam Chair. So, Madam Chair, I would like to move the A9 amendment. Sorry, I missed it earlier, the opportunity, but our virtual committees overlapped and I had to present another bill. So.
Thank you. Senator Curran moves the A9 amendment. Could you explain to us what the A9 amendment does?
Thank you, Madam Chair. And so the A9 amendment, just want to make sure the intention is to not ask for a vote today, but it really follows along the conversation of what we've had. I'll try to streamline it because many of the testifiers have covered a lot of the things that we're seeking. The amendment before you does 2 things, and the key is to get the language in front of us, and as we continue to watch this amazingly evolving process. But this amendment does 2 things. It really gives the flexibility for the private sector to respect, to ensuring some of the cost savings that are actually achieved through telehealth and I think telemonitoring and whatever we deem it in the future. But that it really is an opportunity that those costs are then passed along to the constituents and the consumers. I also believe that we really are on the cusp of delivering medical care, telehealth, and again, whatever we do as part of the equation. And this amendment seeks to give the providers and health plans the flexibility to make sure that we really are paying for value and not for volume. I say that from my own personal experience and the amazing limited telehealth or medicine in relative to a private office visit for some common ailments. I am a massive fan, and we need to make sure that we promote that. The other part is that, you know, some of the most recent articles in the Commonwealth Fund have shown that, you know, without some of the guardrails and barriers, that we could also drive up the costs with telehealth. And so this looks to address that. The second part of the amendment really removes language that prohibits the existence of virtual networks in the state of Minnesota. And these are going to be really, I think, a key tool as we move forward to give the healthcare industry the ability to reward innovation and without breaking the bank, and that we're all working together. And Madam Chair, with that, I think the reality is we're a long ways from where we were just in 2015. And I think we've all, in all the conversations and the testimony that we've heard today, I think everybody does see the hope in the future and the opportunity that really is before us. We're going to need to be probably much more nimble than we are typically in the legislature to be able to address these issues. And I'm looking forward to it, not only from the overall total healthcare and the accessibility to healthcare, but again, serving on the aging as well. I really think this is going to be the opportunity and one thing that will drive that innovation and make sure we foster it and provide the greatest level of care to everybody. As we age at home, I'm a baby boomer. And so I'm hoping that we have access to great care to keep me home as those years progress, and that we give families and the healthcare industry the tools. And I think that's what we're talking about today. So I appreciate Senator Rosen and you, Madam Chair, for allowing the conversation. So with that, I would certainly withdraw my amendment. Thank you.
Senator Curran withdraws the A9. Senator Rosen, even though the language has been withdrawn, do you have any comments to Senator Curran's concerns?
Well, Madam Chair, yes, I think, as I said from the very beginning, this is the start of the discussion. It's going to be, we're kind of in uncharted territory right now. And I really look forward to working with the stakeholders and obviously Senator Curran on this too. It's a good start. No one has given me a medium point between the repealing what we already have or keeping 1160 going forward. So working on a compromise in between there. And so anybody having any creative ideas, please let me know, because I can't repeal and go back on 2015 language. I could certainly, we can certainly adjust, but I'm anxious to work on this going forward.
Thank you, Senator Rosen. And I just reviewing quickly the amendment language on page 2, line 26 and 27, that there would be no limit to geography, location, or distance for travel. And then the suggestion that it should be within your network without limit on geography. I think I understand what you mean. They can't tell you, oh, you're too far from the hospital or too far from the clinic. You can't come in, but I think there needs to be some balance there that you don't just get to pick any provider anywhere in the state of Minnesota. So I think there's some things that as this language is public longer, we're going to have to work out. And Senator Rosen, agree. I don't know if it's a middle point, but there's got to be workable language for now and moving forward. So, Senator Abler.
Well, thank you, Madam Chair, and Senator Rosen for your work on here and just in the big picture. 2015, it was like, wow, cutting edge, let's get going here. And now it looks like the dark ages. And I think in 5 years, this bill will look like, horses and buggies, and because so much is changing. And I think the Zoom world is upon us. I don't think, I doubt we're going to go back to fully in person, just because some people are going to want to dial in from being stuck somewhere into the legislature. And so, but just a few comments, and I think I'll have only one comment on the bill, and that'll be this one now. And so, just to the discussion about networks and the pricing parity in particular, Mr. Andreessen commented that more telehealth might result in more utilization. That would imply to me that the utilization was not sufficient for the demand that was out there if it's causing more use. My view of networks is they're often used to suppress utilization while not suppressing need. And that's where a lot of the savings come from. And I've never been a fan of limited networks, even though they do save money, because I believe they save money by not letting people get appropriate care. And so that could be a whole meeting discussing that, but that's just my opinion as I observe. And so by the same token, these virtual networks that are going to help modern products are going to be full of people that nobody knows, and people aren't going to feel comfortable, particularly in the mental health arena where there takes a long time to get a rapport and a trusted relationship. So Senator Rosen, I believe you're correct to move slowly in that direction. And if ever, I was late to the meeting. I had a bill about networking, contracting, and networks. And very often the networks will seek to exclude some really good providers who are willing to provide all the services they ever wanted, going with a more limited geographic thing. And in fact, they can kick them out without cause. And if they do have a cause, they don't even have to tell them there's no process. And so I just urge everybody to be aware of this limited network thing, and it'll save money, but somebody will come to harm. And so I think Senator Rosen, you're on the right track there. And more work to be done as we sift through this, and what happens 6 years from now, who knows what. The second thing has to do with what we pay. And, you know, some of these things take just as much work. I listened to the psychiatrist. He said he has to do all the stuff he ever did. But I think some things don't take just as much work. I think the clinic of the future is going to be smaller. I think they're going to have telemedicine rooms, and they'll hire doctors to do just that in their network. And so they're not going to need so much support staff. You won't have a front desk. And so I think truly the costs are going to be reduced. I put a bill in just to create a discussion. That's not something in the final version, but it suggests that we do need to pay attention. And I want to also caution members, since this is a finance committee, all the money that's drifting down from the feds, billions, literally billions of dollars to Minnesota in this arena, is making us think this money is going to be endless. But I want to caution folks that the tails, the expenses going forward into 24 and 25 and beyond, are not going to be supported by this one-time money. And we may very well need to find some way to shave some savings. And the more targeted, the better. I'm almost done, Madam Chair, but there's only 3 things that we do in this committee. We serve people, we give them something, and we pay something for it. And so if you serve less people in some way and take something away that from a person, the person can't come, or you take away something that they're getting, that's a way to reduce costs or rates. So I think just going forward, we'll need to pay close attention, because I really don't want to reduce any rates to anybody. But we're going to be having some very big challenges coming up in a couple of months. So I'm happy to be a part of the discussion. I think the testimony today was excellent, and all the voices together. Senator Rosen, good job, and I'm happy to be part of the solution. Thank you very much, Madam Chair.
Thank you, Senator Abler. Next, I have Senator Nelson, then Senator Wickline.
Thank you, Madam Chair. I just wanted to add my voice to the importance of this bill, and really thank Senator Rosen for the very broad discussions that have been taking place, and for the excellent support today, and also those areas where things can be, as Senator Rosen said, teased out just a bit more. And I do believe that telehealth is one of those things that we have embraced more out of a need of necessity during COVID, but it is one of those COVID lessons that we have learned going forward that I think is really going to help more Minnesotans get the high quality care they need, where they need it, and when they need it in all areas. And I am so incredibly thankful for really this hearing today and the very diverse, respectful viewpoints. I appreciate the extra work that's going to go into this bill as it goes forward. And the one thing I would note that I did hear some discussion about more utilization. And I really think the discussion should not be about more utilization. It should be about overutilization. So the fear would be that there would be overutilization or utilization in a way that was not beneficial to the patient. And so I think that's an important distinction going forward. But a great job. I look forward to being a part of this solution as we go forward. And I just say, medical innovation is changing so quickly, and we will be back year after year, making sure that our legislation is keeping up with the innovations. And I'm thrilled that we're moving in this direction today. And thank you, Senator Rosen.
Thank you, Senator Nelson, Senator Wickline, then Senator Klein.
Thank you, Madam Chair. Just some comments. I wanted to raise one concern about how we make decisions in this bill going forward when we may not have maybe enough information or data on how telehealth is being utilized, and how we need to anticipate that we need to gather more data so we make sure we make the best decisions. And I guess what I'm leading to is the Department of Human Services did conduct a telemedicine utilization study that published a report in December. And one of the things that they brought out in that in their findings was that there was less increase in utilization by people of color and elderly in terms of utilization of telehealth services. And so I hope that as we are looking at solutions with this bill to problems we see, that we also look for ways to understand why that might be, that there is a lower take-up rate with our communities of color and underserved populations. And I think that the department had some recommendations about conducting more study and focus groups and analysis of data. And so I hope that, I don't know how to build that into your bill right now, but I hope that we have a discussion with the department about, do they have the resources to do that additional study and understand how that might impact how we create bill language. And maybe that can be done, you know, in the meantime, by the time it comes back to Senator Benson's committee, maybe we have more insight into that. And then as far as the secondary networks and the question about payment parity, I think it's really good that we have a discussion about how to look for ways to address cost for consumers and, you know, patients, and making sure that they're not seeing increases in costs and finding ways to make healthcare more affordable. But we need to be careful about how we do that and making sure we aren't creating barriers, as Senator Abler said, to accessing services by these different networks or by payment methods. I do think that having discussions about, you know, value and paying for quality definitely should be a part of our discussion, though. And if we can have quality at a reduced cost, I think that's important that we have a way to access those savings. So those are just some thoughts, and I hope to keep continuing the discussion going forward. So thanks.
Thank you, Senator Wickland. And Senator Rosen, are you to Senator Wickland's point?
Yes, thank you, Madam Chair. And I will keep my closing comments brief if I could just comment on this. I did read the telemedicine utilization report and talked twice with Department of Human Services, Senator Wickland, and I fully understand their issue with the quality of care and the utilization disparity on utilization. Is that the people of color, the aging, the MA recipients, are they only going to receive a audio consultation, whereas the private pay will have an option between audio and visual? Those are things that are going to work itself out. I don't think that's going to happen, but it's definitely, I think, because the people of color, the disabled community, the aging, they didn't know they could do a telephone phone call until COVID hit. And so now utilization is up. I don't want to penalize telehealth just because utilization is up on a parity issue. So I'm really careful and maybe a little protective about that, but I understand also that we have to get it right. And I know Senator Dr. Klein can speak acutely to this, but I have been working with DHS. I don't necessarily agree with what they're saying about it, that they don't agree that there should be telephone, that there should be a difference in parity for telephone. I disagree with that, but that's a conversation that's going to continue. I promise you.
Thank you, Senator Rosen. Senator Klein.
Thanks. Yeah, and thank you, Madam Chair, and thank you, Senator Rosen, for bringing the bill. Obviously, I support the bill and I'm so grateful for the work you've put in on it, and working with Dr. Morrison in the House as well. I actually was going to make almost the identical points that Senator Wickland just made. Number one, that this really should be an opportunity to address our equity issues in our state, not only between people of color and white people, but also between urban and rural access issues for healthcare access. So let's make sure we're thoughtful about that and that we actually achieve, what seems obvious should be a tool for addressing equity issues. And then also, the concerns that have been raised about overutilization or inappropriate utilization really can be addressed if we use this as an opportunity to revise payment processes so that we incentivize quality and outcomes and value rather than quantity. And I know every other speaker has already spoken to that, but it's a big opportunity. Thank you, Senator Rosen, for the bill.
Thank you. Senator Rosen, closing comments.
Well, Madam Chair, I promised you I was going to keep it short, but I don't know if anybody has done a virtual visit. They're amazing. And I just had one last week, and I was able to use my provider back in Fairmont instead of having to go to a Minute Clinic or something around here. So it does have that component too that we haven't addressed. We are not going back. It's like working from home. Things have changed because of COVID. Things have changed, and so we need to get this uncharted territory correct, and we will, because we've got everybody at the table and we're moving forward. But I reminded a couple of my colleagues last night and people I've been working with that may not like the bill completely, but you're going to respect it because it has everybody's opinion in it. So, Madam Chair, I know we're coming back to you. I'll save the really good stuff for later.
Thank you. And Senator Rosen, I think so many times in the legislature, we need to remember that we can't let perfection get in the way of good. And so let's focus on good. Keep working on this. We're gonna be making adjustments for a long time coming. With that, Senator Rosen, your motion will be Senate File 1160 as amended, be recommended to pass to the Committee on Commerce. So please move your bill.
Thank you, Madam Chair. I'd like to move Senate File 1160 as amended be recommended to pass and sent to Commerce.
Unmute yourself, turn on your video. All those in favor say aye.
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 Any opposition? Hearing none, Senator Rosen, you are on your way to Commerce. Thank you for your work on this bill. And members, that concludes our business for today. We'll see you again on Wednesday. We are adjourned.